Thank you all for having me. As I have been introduced, I will tell you about a pilot study where we studied the feasibility, safety, and tolerability of intra-dialytic creatine supplementation in patients receiving hemodialysis. And this is the whole, a part of the team that has been busy with this last couple of years. We have been supported by Creatine for this study. So I will keep the introduction quite short because Adrian already told you a lot about this. But as we all know, it's a natural endogenous substance with a lot of important functions in the human body. So once again, why are we interested in patients on hemodialysis? Like Adrian also already said, a lot of the first step of the synthesis endogenously takes place in the kidneys, the formation of guanidino acetate. It's then transported into cells where it has its function, and a part of it is degraded into creatinine on a daily basis, which leaves then the body via the urine. The problem when your kidney function, it doesn't work the way I thought it would. The problem when your kidney function declines is that this first step of creatine synthesis will work less, and therefore your creatine synthesis will go down. If you also take into account that nutritional intake of creatine is reduced in many patients receiving hemodialysis due to malnutrition, due to restrictions in diet, and due to some symptoms they can have, the positive part of the balance in creatine on a daily basis will go down. And also, as Adrian already told us, there are also additional losses into the dialysate next to the degradation into creatinine. So these patients are at risk for developing creatine deficiency over time. Therefore, we aimed to study the feasibility of creatine supplementation inside the dialysate. So we put the creatine in the dialysis machine, in the fluid where all the things go. I don't know how to say this. And we did this by measuring the intra-erythrocytic creatine concentrations as a marker for intracellular creatine uptake. Also the plasma creatine concentrations and the creatinine excretion as a marker for the total creatine pool in the body of the patients on hemodialysis. The second aim was to study the safety and tolerability of this method of creatine supplementation in this population, and we wanted to find an optimal dose for this way of delivering creatine as well. And we also collected some pilot data on clinical effects on muscle status, nutritional status, neurocognitive status, fatigue and health-related quality of life, but I will not go into much detail in this presentation about this part. So, first of all, a sterile solution was developed of 50 millimole per liter. Which was tested for stability, and it was very stable over time, and even when refrigerated, it was stable for months. And then we had to include 16 participants in this study. They had to be over 18 years, and they had to be dialyzing for at least 2 months, so they had some time to develop a deficiency. That was the rationale behind this. And there were also some exclusion criteria, which I won't go into much detail about. We included the patients in 4 different groups who received 4 different dosages. The dosages that you see is 0.5, 1.5 and 2 millimole per liter inside the dialysate. So we actually adjusted the flow of the creatine, the 50 millimole creatine solution into the dialysate to get the concentration that we wanted to deliver to the patient. And the highest dosage, the 2 millimole per liter, is similar to what you have in your plasma after eating a very creatine-rich meal. And therefore, we thought this is a very logical amount to go for and safe. The patients were inside the study for 8 weeks, every person, and they received creatine or a placebo for 6 weeks during every dialysis treatment. Most people in the study received this 3 times per week, some of them 2 times per week. We performed study visits at the baseline after 3 weeks, after 6 weeks, and then we had a washout period for 2 weeks, after which we performed another study visit. So here you can see the creatine was added in the afferent side of the dialysate, just before the dialyzer, so just before the membrane where the exchange with the blood of the patients takes place. During the study visits, we collected samples. We collected inter-dialytic urine collections. So this is urine collection from starting from the last dialysis session before the study visit, all the way up to the dialysis session of the study visit itself. For most people, this was 2 days. We did blood sampling before and after dialysis, immediately before and immediately after. And we collected the whole dialysate, 120 liters, and you see it here again, the tank in which we collected it. And we measured creatine, creatinine, and guanidinium acetate in all of these substances. We screened 50 patients. Some of them were ineligible due to the in- and exclusion criteria that you saw before. Some of them declined, and we randomized 19 patients eventually. I told you we needed 16 to include in our analysis, and but 2 were excluded due to unrelated adverse events, and 1 was eventually excluded due to a side effect. As you can see here, we had a very broad population with a lot of variation in, for instance, age, but also a lot of variation in concentrations inside erythrocytes and plasma. Therefore, we looked at mainly the changes in these concentrations over time. Here you can see inside one dialysis session the uptake of creatine in the body, which we calculated from all our measurements. At the visits 1, 2, and 3, where we received creatine, you can see that there was a very dose-dependent uptake of creatine, and in visit 4, they didn't receive any, so there's no uptake. And in figure C, you can see the change in plasma creatine concentrations per session, so before to after, which is also a very strong dose-dependent relationship. And over the course of 6 weeks, we saw increases of pre-dialytic creatine concentrations, which were also very dose-dependent. In figure A, we're looking at the intra-erythrocytic creatine concentrations, and in figure B, we are looking at the plasma creatine concentrations. So especially in figure A, we see there is a very strong dose-dependent relation. Even in this very small population, it was a very significant effect. And when we look at the total estimated creatine pool in the patients, which was the combined creatinine excretion from urine and also in the dialysate, we had some missing data on the urine collection. So in A, you see the numbers from only the first 3 groups, but there you can see that it goes up. It is just not a very statistically significant effect per group, which you cannot really expect in such small group sample sizes. But we also looked at the dialytic creatinine excretion, and the ratio between the dialytic excretion and urinary excretion was very stable. So this is also quite a good marker for overall creatinine excretion. And it seems there is an effect, but in the second highest group, for some reason, it didn't go up over the 6 weeks. But there might be some error. There were some adverse events, no harmful adverse events. Some headaches, some dizziness, but most of them were in the placebo group actually. And in the creatine group, 2 persons experienced nausea, and one person experienced an altered taste. And these two were very related to the creatine treatment, so we thought these are probably potential side effects, and the other persons did not really experience side effects. So, how do we interpret this? Well, per dialysis session, we saw dose-dependent uptake of creatine, dose-dependent rise in creatine levels. And over the course of 6 weeks, we saw dose-dependent rise in creatine concentrations as well. It seems there is a rise in creatine pool, but we need a little bit more data to conclude this. And we also might observe a small decline in creatine uptake per session, which might look like a ceiling effect, might look like there is more saturation of the creatine pool in the body. So we concluded it was feasible to deliver creatine to the body in this manner. Looking at adverse events, most were in the placebo group, which is of course good for the creatine study. Most were unrelated to the study, and nausea and altered taste were probably related to the creatine supplementation. One person actually dropped out due to this. The other person was fine with it and could finish the study. So in our study, it was generally well tolerated, and it was safe as no harmful side effects occurred. Some strengths of our study is the randomized placebo-controlled design and the complete capture of dialysate, which allowed for many calculations about the creatine delivery. And some limitations inherent to a pilot study. Of course, we had a very small sample size and a short duration of the study, so we could not really observe clinical benefits yet in this pilot study. So, to conclude, intra-dialytic creatine supplementation is feasible, safe, and generally well tolerated in our population. All doses were well tolerated, and the highest 2 doses were most effective at 6 weeks for supplementing creatine. And future research in a larger cohort with a longer period of time, and preferably with a form of physical stimulation or exercise, is needed to show the clinical benefits in this population. And on top you see a ChatGPT picture of a very strong kidney, which we sent as a thank you card to all of our patients in the study. Thank you for your attention.